Hello, everyone. Hello, welcome. Happy Friday. We made it to the end of the week. It looks like most of our attendees are here, and so I'm go ahead and get started. For those of you that don't know me, I'm Christiana Letterman, the Director of Alumni Relations and Individual Giving here at the Tulane School of Social Work. I'm so pleased to welcome you all to our first Alumni Lunch and Learn session in 2021. This Lunch and Learn series is a new initiative created to provide free continuing education credits to our school's alumni base, our faculty, our staff, and students. And I'm excited to be able to offer 4 of these annually going forward, so keep an eye out for upcoming dates with those. Just a note, I will be sending out your certificates in the next 7 to 14 business days, so please be patient with me as I get those together for you. I know after a year of using Zoom, most of you are pros at the platform at this point. But as a reminder, as we go through the session today, please use the question function if you have any questions for Dr. Hill during the presentation, so we can keep those streamlined. Otherwise, you can use the chat function to communicate with myself or Carrie Mulder, who will be moderating today, if you need any support or have any issues with the platform. So without further ado, I would like to introduce to you our facilitator for the day, Dr. Margaret Hill. Dr. Hill's interest in trauma began in her MSW field training, where she provided counseling to youth involved with the foster care system and their families. Other social work experiences, including helping to establish and manage an adult mental health IOP and providing therapy in an acute psychiatric facility, furthered her interest in understanding the impact of trauma. Today, she is a psychotherapist in private practice, primarily seeing adults and older adults with trauma, especially those with early interpersonal and childhood trauma. Dr. Hill uses a variety of approaches to treating trauma, such as EMDR, CBT, psychodynamic, neurobiological, attachment-based, and emotionally focused approaches. Margaret is an adjunct professor in the Hicks School of Social Work at the University of Texas in Austin, where she often teaches a course on trauma assessment and treatment to the MSW students. She earned her doctorate at Tulane in December 2020, so congratulations again on that amazing achievement. Additionally, Margaret lives in Austin, Texas with her husband and her cat, and she enjoys spending time with her older adult children and grandchildren. So Dr. Hill, thank you so much for facilitating our session today on trauma and its impact. The screen is now yours.
Thank you, Christiana. I appreciate that introduction. Howdy. Hey, y'all. Welcome and bienvenidos. I want to have a very quick shout out for 1 second to my peeps from my doctoral program. Great to see you all, or not see you as the case is, but I appreciate your showing up for me. A few things first, just as we get started. I acknowledge that I have privileges of a white, cisgendered, able-bodied person, among others. And these privileges influence how I experience my work. And it influences how I move through the world. And I just want to be aware that not everyone has those same experiences, and we all have important things that we can share. I also want to say, as I go through the presentation, I'm going to talk in 3 different voices, sort of 3 different ways of knowing. In one way of knowing, there's research, what we call evidence-based. And in that case, I will tell you that there is research to support what I'm saying. There's also practice wisdom, which, although there hasn't been enough research to provide evidence yet, it's kind of commonly accepted among social workers that this is true. There would be a lot of people who would hold this same viewpoint. And finally, there's my personal opinions, Margaret's unique view on the world. I'm going to talk about all 3 of those things, and I'm going to try and tell you as I go which one I'm using, so that you can keep it straight. What we know through evidence, what we know through practice, and my opinions. I've also, just to let you know, I've used burnt orange as we go through this text. to highlight key points. I want you to remember to practice self-care through this presentation. It's important to acknowledge that trauma is a difficult topic, and there may be things in here that are upsetting or triggering for you. And if that's the case, I want you to do what you need to do to keep yourself safe. Step away from the presentation, stand up, walk around, get a drink, stretch, yell, whatever it is you need to do. Maybe even stop if it gets to be too much. And I hope it won't. And I will do my best to be gentle and to warn as we get near difficult material. But I also want your experience of this to be comfortable and safe for you. I'm going to say a little bit more about self-care. Self-care is extraordinarily important in the field of trauma. And why is that? Because we do our best work in trauma and in everything else that social workers do. We do our best work when we connect. But connecting to people, especially people with trauma, is difficult. It's disturbing. It's triggering to us. Their extreme experiences and the severity of their symptoms can be very hard for us. And so I want to make sure that you are thinking about burnout and you are thinking about secondary trauma. Burnout is the feeling of being tired of coming to work, overwhelmed, feeling exhausted, not caring, not wanting to be involved with people. All of us feel that a bit from time to time. Some of us experience it even more strongly. And there's also in the field of trauma, the difficulty with secondary trauma, which is when other people's trauma gets on us. And it's kind of sticky. The trauma kind of attaches to us and it's hard for us to get it. It's almost like we have honey on our fingers. We have trauma, we touch somebody, then they have the sticky on them. And so how do we manage a career when we are at risk of experiencing burnout and we're at risk of experiencing secondary trauma? I say self-care. And how do we do that? Well, first of all, everybody does self-care in a different way, right? We have different things. Extroverts might like to join a group, play a team sport, go out for a night with friends. Introverts might stay home and read a book or take a walk on their own. So remembering to find things that create that feeling of bringing yourself back down to calm, bringing yourself back down to ground, and allowing you to discharge. It's almost like an electric feeling, discharge the trauma of other people that has gotten on you. However, it's very important that we do not traumatize other people. So I use a particular language. I'm going to change the angle of my camera here for just a minute so that you can see more of my body. I'd like you to try this. I'd like you to put your hands on your chest, and you can see they're pretty high. They're not down on my belly. They're up here, right on my rib cage, right? Both hands. This is making a shield. This is my shield for difficult material, and I'm protecting my heart, right? And so I use the language shields up, right? We're talking about something and I say shields up. It's time to put your hands here just for a second to remind you you're about to hear something difficult and you may want to create a little barrier for that so that it doesn't hit you too hard. As we're talking to other people about our trauma, or as we're talking to other people about the trauma our clients have passed to us, I think it's very important to stay aware of the impact that's going to have on the listener and to remind them to put shields up. So as I go through today, I will use that shields up language. I also just threw this next point on here. Organizationally, what can you do? A lot of us might be in positions where we're part of a work unit. Maybe we even have some folks that we're supervising, perhaps even interns or more junior staff. So we have a little bit of influence in our organization. Some of us might have quite a lot. What can organizations do to support self-care among their staff? Because clearly you can't just leave it to the workers to do it for themselves, right? We can't just abandon them with this difficult problem. Organizations have to take some responsibility for helping as well. So here's some ideas, and there's many, many, many others, and I encourage you to look into this and think about it if you're at all interested. One way is to allow folks to step out, sort of like I just did at the beginning of this presentation. I said, if you're having a tough time, it's okay to step out. It's okay to say, I need a minute. This material is too difficult. This is my particular trigger, and I need distance from it. That's all right. It's also important to make it okay to admit that you're struggling with self-care, you're struggling with burnout, because if you can't say that to your coworkers, then you are truly alone with it and you don't get any recognition and help. And so organizationally, we need to make it okay. Often we act like we don't want to hear that. It's actually very important to hear that, and to be able to have an organizational response. Another kind of category of responses organizationally, offer some solutions. Have somebody lead a yoga group, organize games at lunch, organize lawn bowling, organize card games, set up a walking trail, allow people to form a walking group or an exercise group at work, create a space where people can go de-stress, a space maybe with a few comfortable chairs and some soft music would be a nice way to do that. Or maybe even offer, a mental health day off or mental health time off on a regular basis, or for people that acutely need it, either one. Lots and lots of different creative ideas here that you might consider. What I want you to take away from this is not so much the particular ideas, but the importance of this idea that self-care and managing triggers, managing burnout, managing secondary trauma is an essential part of us being able to do our best work. And so we need to do it ourselves, and we need to support those people around us who are doing it also. I'm sorry, I'm having a little bit of trouble managing my cursor. Here we go. Changing the slides. All right, Jill, I got my slide changed. On to talking a little bit about trauma. Beginning the information about trauma. I like to have all of these definitions. Every one of them contributes something unique to the ways that we think about trauma. This is my very favorite one, this first one, which is why it's first, because it's the favorite. A normal, healthy response to an abnormal, unhealthy situation. This one is really important to me because it's very validating and helpful to folks with trauma to hear that this is the way our brain is designed to respond. It leads to some consequences that are tough to manage, but it is your brain's attempt to protect you from something that's overwhelming. It's sort of like a car, if you can imagine, as you put your foot on the gas and as the trauma is getting more and more intense, you're putting your foot on the gas more and more, the engine starts racing. At some point, there needs to be a way to make it stop. So before your body and your mind get completely overwhelmed, your mind will actually shut off. And this is helpful. Like I said, it can lead to some bad consequences. It can linger too long and other things. But that shutoff valve is absolutely essential for safety, mental and physical safety. And so when people have experienced trauma and then they've had some reactions afterwards to that, that's important for them to know that it's normal. It's the way the system's designed to work. Second definition, sorry. The result of something bad that happened to you, not something that's weak, crazy, ill, broken, effed up, all the things that clients say about themselves. They feel weak or crazy, but it's not something weak or crazy about them. It's something that happened to them. And this is great because you recognize this immediately as a way to externalize, right? It's not you, it's this outside thing. And again, that's very validating and helpful to clients. Trauma is your body and mind's best efforts to cope with a psychic wound that you received. I like this definition because I like the word wound. We often pay a lot of attention to physical wounds. You know, it's not uncommon to see people with bandages or casts or stitches, but we don't often recognize that it's also possible to get a mental wound, an emotional wound. And so when we think about it as a wound, that allows us to then start thinking about what would it take to heal that wound. If we think about it as broken, there's not much we can do about broken, but wounded, that's something we can help. Trauma is not what happens to us, but what we hold inside in the absence of an empathetic witness. This is Peter Levine, a well-known trauma guy. Trauma is not the event itself, but it's how the event impacts us. And that's what he means by what we hold inside. It's how it changes us, how it hurts us, how it limits us. And so that helps people too, that it wasn't because you had a car accident, it was because you had a car accident and then that hurt you, or that scared you, or that made you angry, right? So it's what happens inside, not the event. Trauma is a severe disruption in our ability to connect, and that includes with ourselves and other people, and also just with the world, with our jobs, with our communities. And I like this definition because when you have a client who has trauma, you often tend to think about how isolated they are or how difficult relationships are for them, how they struggle in that area, maybe even struggle to form a connection with you as a helper. And so it's important, I think, to hold in mind from the helper's point of view, this person has a disruption that's making this hard for them. It's not because they're uncaring or they don't want relationships. It's because they're having a hard time with them. And then this last one is also a favorite of mine, and I have a poster of it in my office. It says, trauma is anything, any event, any situation, any person that prevents you from becoming who you truly are. Safe Alliance is the domestic violence shelter here in Austin. And this is their definition, and I really love it because, again, although it acknowledges the difficult piece, the prevention piece, it's preventing you from something, it also acknowledges sort of the hope, the possibility of change. From becoming who you truly are is a phrase that to me has a lot of hope for the future. And it guides me as a therapist in how to look at this person and how to think about helping them. I also just want to say a little bit about types of trauma. And there's at least two ways that we think about different types of trauma. One way is to think about impersonal trauma and interpersonal trauma. So one is not personal and one is personal. Impersonal trauma is what we typically think about when we think about trauma. So we think about war, we think about accidents, we think about natural disasters, we think about those kinds of events. And that seems traumatic, right? That's fairly easy to understand how disturbing those events are for people. Equally important, though, and often overlooked, is this category of interpersonal trauma. And interpersonal trauma is caused by someone targeting someone else, or some group or person targeting some other group or person. So things like the experience of racism, sexual harassment, child abuse, domestic violence, assault, being a victim of a crime. These are traumas that occur between individual people, and you can understand that the experience of being hurt by a family member, physically hurt by a family member, is very different than the experience of living through a flood, right? It has a different quality to it. Not only has the horrible thing happened, but the horrible thing has happened because somebody made that happen and they targeted me, right? And so this is a very important distinction to keep in mind. And here's why. As we first learned about trauma, thinking about Vietnam era veterans returning and trying to integrate back into society after combat. And those are impersonal for the most part, experiences that they had being caught up in that war. And as we started to learn more about trauma, though, we started to recognize that trauma can also occur in this sort of smaller, more personal, more targeted way. It doesn't have to just affect huge groups of people going through awful events together. And we used to think that impersonal trauma was sort of big, important, significant, and worth paying attention to. And interpersonal trauma was just sort of personal problems, was sort of like not as much, not worthy of as much attention, not worthy of being considered big, right? It's a small problem. If you and your family are experiencing a problem, it's not like a war. And that it's true, wars are big and family problems are small in that sense, in the number of people affected. But what we find out, and this is an evidence-based finding, is that interpersonal trauma is more severe than impersonal trauma. It, on average, takes people longer to recover, and they don't recover as well from something that happened in an interpersonal interaction compared to these bigger impersonal events. So you may have heard this old language, which we don't use anymore in the trauma field, of big T trauma and little t trauma. If you've been around a while, you may have heard that. We no longer use that language. That implies that the big T trauma is big and hard to deal with, and the interpersonal trauma is small and easy. It's actually the other way around. The interpersonal trauma is the more difficult trauma. So it's important to keep that in mind as you're looking at people who have trauma. While they may be describing a very small personal situation, the trauma impact can be profound, and it may be more profound because it's a small situation. The other way to kind of categorize and think about trauma is to compare individual trauma with community or historical trauma. Individual trauma being trauma that happens to one or just a small group of people. So, and a car accident is an example of an individual trauma. And I think that's pretty easy to see. And again, that's what we consider sort of the typical kinds of traumas, individual trauma. We live in a very individualistic society, and we tend to focus on the individual, and we don't think as much about communities, particularly communities that might have had historical events that have trauma that's gone down through generations. But increasingly now we're starting to focus more on communities. And to me, that makes a great deal of sense because community trauma has affected large groups of people, many, many, many people, not just one or a few people. So focusing on community trauma, we have the potential to have a bigger impact. And there are treatments that deal with community trauma, and we're in the midst of developing more right now. It's very exciting. Part of the field to be in right now. There's also this idea, as I said a minute ago, that things pass down through generations. And so imagine communities that are disadvantaged, that have been discriminated against, that are experiencing social problems like poverty. Those problems tend to persist within those communities, creating a historical trauma event. So it's not just I've experienced, let's say, homophobia, but everyone in my community of queer folk has experienced homophobia. The older people in the community, the people before them, the people before them. And so as you look back in the queer community, you can see that everyone through time has experienced different forms, different types of trauma. And so it's not just my personal reaction to a homophobic event. It's my whole community's reaction to homophobic events that have been going on for a very long time. tried to make you a slide to talk about events, because I'm emphasizing here that trauma starts with an event. That's part of the diagnostic criteria in the DSM-5. The first criteria is that there must be an event. Trauma comes not so much from the event, but from the impact of the event, from the reaction to the event. But it's important to think about what kinds of events are we talking about. Remember that I said that we used to think about trauma as these big events. Combat experiences was a good example. Other types of events that affected, many people in an impersonal way, natural disasters, and so on. This list includes some of those. So you'll see things like political unrest. You'll see things like combat experiences. All of that is here, but also many more personal, smaller events that affect a community or affect families or individuals. And this list is probably a lot bigger and a lot more varied than you thought it would be. At least I'm hoping that's true, that this list is expanding your conception of what could be considered an event leading to trauma. I have to tell you, when I started writing this list, it was twice this long, and I couldn't shrink the font small enough to get all of my ideas on here. So I had to really edit, and I ended just saying more ... because there's a lot more that could go on here. So many kinds of experiences could be the events that lead to trauma, depending on the reaction of the person. So for example, car accident. This is a very classic, event that can lead to trauma, sort of a iconic one, almost like a case study. Imagine a person who gets in a car accident, and other than, being shaken up for a few hours and then having the hassle of having to deal with the insurance company and looking for a new car, they're fine. They don't experience any psychological reaction to that. It didn't really create a psychic wound for them. Other than the first few hours, might be a little shaky or a little scared, but pretty quickly recovers. Imagine another individual, very same car accident, very same situation. However, the reaction in them is big, right? And they afterwards feel shaky, but then that moves into, they feel terrified, they're afraid to drive, they start avoiding cars, they become maybe even agoraphobic or not wanting to be out in public if they can see cars. Thinking about driving makes them scared. They can have many psychological reactions to the fear that goes along with an accident. And so it's not the event itself that creates the trauma. Some people will have a car accident and be fine. Some will have a car accident and it will lead to lasting trauma. So it's not the car accident, right? It's the reaction of what is going on inside the person when they face that event. I want to do a couple of exercises with you, and we're going to keep doing these as we go, because I'm going to teach you some skills. Here's what these skills are good for. Number one, these skills are good for helping you avoid burnout and secondary trauma. So they're good for self-care for you. Secondly, these skills are also good for teaching to your clients, so that they can learn how to ground and regulate themselves. So I'm teaching you something that I want you to use for yourself, and I also want you to use for your clients. Here's an exercise, and I ask each of you to follow along as you feel comfortable to do so. And if at any point you don't want to follow along, please feel absolutely free to ignore it. Stand up now and get a drink of water, or do whatever else you need to do. Don't feel pressured to participate if you don't want to, but you can if you like. First of all, a breathing exercise, and you guys probably know some. I would imagine almost all of you have at least been exposed to breathing exercises. Here's a very short, very simple one. Every time we breathe in with an inhale, our mood goes up a little bit. We get a little burst in the brain of the neurochemicals that help bring our mood up, help create energy, right? And every time we exhale, there's a little bit of the opposite. We get a little burst, just a tiny burst of the chemicals that bring us down. So every breath, our mood is going up, down, up, down, up, down, up, down in this tiny pattern over and over again. Once you know that, you can use it to your advantage. And here's one way. In order to calm down, then, we're going to emphasize the exhale, and we're going to make the inhale fairly short. So I'm going to count out loud, count of 4 to inhale, and then a count of 6 to exhale. Here we go. 1, 2, 3, 4, and then out. 1, 2, 3, 4, 5, 6. Right. Making the inhale shorter and the exhale a little bit longer. Let's do it again. In on 4, out on 6. Here we go. 1, 2, 3, 4. 1, 2, 3, 4, 5, 6. I'm exaggerating a little bit with my body so that you can see the inhale and the exhale, right? If you use this exercise, you should only do it for 3 or 4 or 5 breaths, and then you should stop and breathe normally for a bit. Changing your breathing can easily cause you to hyperventilate or feel a little dizzy, and I don't want that. But that exercise of breathing in fairly quickly and out more slowly ought to be creating in your brain and in your body a mild but a noticeable feeling of calming. Right? And so when we're talking to our clients about breathing, and we're trying to recommend them different exercises or different approaches to breathing, for helping people that are too high calm down, it's important to emphasize the exhale. When I tell somebody we're going to do a breathing exercise, often the first thing they do is go, and they try to take in as much air as they can. That's exactly the wrong approach. This brings them more up, right? And I'm trying to help them come down. So rather than focusing on the inhale, focus on the exhale, extend that as much as you can. Right? That's one exercise. One more exercise. This one is a very focused exercise for trauma. Again, I'm going to adjust my camera angle so that you can see what I'm doing. I cross my, and I encourage you to try this if you'd like. Cross my hands at the wrists. Here's my hands. And then I place my hands on my chest, my fingertips just touching my collarbone. Here's my collarbone. So here's my hands. So pretty high up on the chest, 2 crossed hands. And then I'm lifting up my hands and I'm tapping myself with a right-left pattern, one at a time. This is called a butterfly hug. And it's easy to see why. Evidence has shown that the butterfly hug helps people calm down. And there's 2 ways that people think that's happening. One way is just a little bit of warmth and a little bit of pressure, right? Not hard, but just gentle pressure on the upper chest has a soothing feeling for most people. On the other hand, if you've had a client whose trauma involves discomfort around breathing or discomfort around pressure on their body, they will not like doing this, right? So always adapting it to what you and what your clients experience as helpful. The other thing, besides the pressure and warmth on the chest that's helpful, is the tapping motion side to side. Human brains are wired, and we don't know why, but we know they are wired to respond to a side to side movement with relaxing and feeling comforted. And you know this if you've ever held a baby. We tend to hold the baby and sway, right? There's kind of this motion of holding the baby. If you've ever seen someone in severe psychological distress, often people will do a rocking motion side to side, right? People find rocking chairs soothing, gliders, swings. People like activities that cause kind of a rhythmic side-to-side movement, kind of a dancing movement. It's also a motion that we make when we're walking or we're running. We're having this rhythmic side-to-side stimulation of our bodies. And that tends to be very regulating of our nervous system. For some reason, we respond to that with relaxation and calm and focus. Okay. Lots of stuff to think about. I'm adjusting the camera back. Here we go. This is a good time to stop and take questions. I wonder if there are any questions that anybody has so far. Christiana, have you noticed any questions?
Yes, I'm going to jump in. We had a question from Mindy that relates back to the types of trauma you were speaking about.
Yes.
And their question was, if someone is sexually assaulted or raped by a stranger, what type is this? Impersonal or interpersonal?
Mindy, that's a great question. Thank you. I would call that interpersonal because even though the person is a stranger, they targeted their victim, right? It's a person to a person hurting someone, and they deliberately picked you and they deliberately hurt you, right? So that's how I'm deciding interpersonal or impersonal. Whereas you don't say, the forest fire came after me, right? The forest fire came after this entire community. I hope that helps. What else?
Our next question is from Monty, and it says, why is interpersonal trauma so impactful? I understand you explained this, but can you go a little deeper, please?
Yes, Monty, thank you. I'd love to go a little deeper. I feel like I don't get to go deep enough, so thanks for that encouragement. Interpersonal trauma is so hurtful because humans are so hardwired to connect to other people. And even if we choose not to connect with other people, we at least sense them. So imagine how you might do something, we have to think pre-COVID days now, but imagine how in pre-COVID days, for example, you walk through a grocery store, right? You may connect in the sense that you might smile at someone, you might make eye contact, you might say thank you, you might say excuse me. There might be some contact there, even with strangers in the grocery store. Even if you don't deliberately contact them, there's at least an awareness. You can just look at someone standing in a grocery store aisle. Most of us are very good at this, and therapists tend to be really, really excellent at this. We can look at people and tell what they're feeling. We can tell what's going on in their heads, at least at a broad level. I can tell if someone's relaxed or tense just by looking at them. I can tell if someone's happy or angry. I can tell if someone's looking nervous. I pick up kind of a vibe. I'm afraid that I'm a person who grew up in the 70s in Austin, and I love that word vibes. It makes everyone else I know roll their eyes, but it's my favorite word. You can pick up vibes off of people. You can read them, at least in a high level way. And so when you are involved in a situation where someone hurts you deliberately, right, does something to you and you are the target and it's another person, that hurtful intention is extraordinarily painful, right? It's always painful to go through some awful, scary, angering experience. But knowing that you were chosen and targeted, and knowing that this was pain that another human deliberately inflicted on you is far worse. So shields up. I'm about to say something a little painful, and I don't mean to traumatize, but remember to protect yourself. For example, a lot of the clients that I worked with in agency settings were teenagers that had been victimized in their own homes and were taken from their families and were in the foster care system. These children had been hurt deliberately, often by a parent or grandparent or sibling or someone who should have been a trusted, valuable person in their lives, instead was a source of pain. And so it's that sense of the target. right? It's that sense of you're breaking the natural order in which humans care about each other, connect to each other, read each other, respond sensitively to each other. Instead, I've been now involved in a situation where someone has targeted me and has deliberately caused me pain. And that's deeply disturbing to our minds. And it's interesting thing about humans that we remain so hardwired to connect in the face of a world that doesn't always make that easy. Yeah. Thanks.
All right. How much more time do you have for questions?
How about one more?
Okay. So this next one is, what is the best way to start unpacking and healing our own traumas within traumas? For example, this pandemic, the trauma of our lives being turned upside down or losing relationships and potentially losing people. How do we unpack that?
There's two things that I recommend. First of all, people have been having trauma as long as there have been people, right? Trauma is not new. And so our ancestors for thousands of years have had traumas and have often been able to recover from traumas without a lot of intervention. On their own, in time, many traumas will become better. I don't mean to imply that that means they were trivial, right? It sometimes takes a lot of effort. But traumas can certainly be healed within ourselves in time, especially with time. However, lots of things persist even with time. And in that case, what has to happen is some type of intervention. And it's interesting because we now have these therapeutic and medical interventions that, we didn't have even 60, 70 years ago, right? Trauma is a relatively new field. Like I said, it hasn't been studied in this way until the 70s, the 1970s. All of human history up to the 1970s then, people invented other interventions. And I'm always interested in reading and learning about these. Think about the ways, for example, that Native American communities responded to trauma. They have types of cleansing ceremonies. They have quests that allow you to sort of get right with the universe. I don't pretend to understand that at any deep level, but I have read about those. Looking at, tribal rituals, looking at collective ways that we mourn, collective ways that we rebuild after a disaster, collective ways that we create community, whether we connect maybe spiritually, whether we connect maybe through service in different ways. How are we specifically going to get through COVID? That's a big question. That's a big question. I recommend talking with people and working it through with small groups or other people that share a similar set of values with you about how to handle it. Because some people want to just push past and move on, and they're going to do best that way. Other people are going to want to have a lot of time to talk through and process and work through what has happened. I think it's helpful to see a therapist if trauma has persisted in spite of your best efforts for 6 months or more. That's my first cut. Things take about 6 months. This is evidence-based. Things take about 6 months to process in our bodies. And so if 6 months later, still feeling it, that's one of my clues that maybe more help would be needed. So 6 months is the time to start thinking about professional help. That was a very long rambling answer, but there are several different ways to approach that question. So I hope that helps. All right, guys, I'm going to move on. And I'll have time for questions more in a few minutes. All right. So now we're starting to talk about the impact that trauma has on us. Trauma is not the event itself, like we said. It is how we react, how we respond. And what is traumatic to one person isn't to another. We don't exactly know why. We have a few theories. Some of them have proven to be true. Some of them are still being tested, but we don't really know exactly why some people get trauma and some don't. One of the biggest answers is that trauma tends to reoccur. And I'll say more about that on the next slide, I think. Trauma is a physical response. I said this from the very beginning. It's not just a psychological response, it's a physical response also. And then it has consequences for us in every aspect of our being, including cognitive, emotional, social, spiritual ways. We are born with the capacity to take in information, process it logically, process it emotionally, respond to it, and then put the result into our memory. That's how our brains are wired to work. And that process begins at birth, and maybe even pre-birth to some extent. And so when that normal process of event, reaction, processing, storage, when that process gets interrupted, the memory doesn't get put in long-term storage. It doesn't get properly processed. The processing step gets skipped, and then the memory doesn't get put in storage. And so what happens is the memory becomes frozen in our minds, and we can't get past it when it has progressed to that state where we're not able to self-heal. And it feels stuck. This is often the word that people use. They say, I'm stuck. I can't get past this event. I can't get past this memory. And that's why physically they're blocked. Physically, the memory has not been processed and stored in memory properly. And so they're not going to be able to get past it. There's a physical barrier. And the trauma therapy becomes about helping to remove that barrier. So then the normal process can then happen. So we're not doing anything in particular to change the memory, change the process. We're just allowing the process to go. And making the process run smoothly. You've heard this too. People are hardwired to respond with different categories of responses. Fight, flight, freeze, or friend are the four that are the most commonly talked about. Friend is also sometimes called fawn. You may have heard that word. We want to flight. We want to run away. We want to fight, meaning we want to attack or defend ourselves. Freeze is when we try to fight, but it's hopeless. We can't win. We're overpowered. And then we tend to kind of go into freeze, which is more like a collapse sort of a state, sort of the deer in the frozen headlights, a deer frozen in the headlights kind of response. And friend is the idea that when a person, this is particularly true in interpersonal trauma, when someone is face to face with us and we feel in danger from them, we often try to do something to get them to like us, or to think of us as non-threatening or as a friend. We giggle. That's a reaction women often have when they feel scared. And it doesn't go together, giggling and scared, but giggling is a way to appear, unthreatening. And so that's a friend strategy. When you can't respond, that's when you often feel the most helpless and the most stuck, and where the physical arousal can stay strong. Trauma can also be triggered by current events. And so it's not uncommon that someone has a trauma from years and decades ago, and then a trigger will set it off again. So one of the things that I observed quite a bit in my practice is people who have childhood trauma, have worked on it perhaps, have healed from it, or have at least come to terms with managing it well. They at some point become a parent themselves, and they have children. And when they look at their children, it triggers trauma in them again. Seeing children behaving like children is very triggering for them. And so memories will get triggered again just like that. I've had clients who've been triggered by watching a movie that had something in common with their their experience. They've been triggered when they've been through something that has some element in common. I had a client who, following a trauma that involved blood, and this is shields up, she was involved in a traumatic situation where she saw blood. She became so scared of the color red that she was debilitated and could only stay home because every time she left her house, she could see things that were red, and they would trigger sort of a flashback reaction in her. So trauma's reactions can occur sort of in the immediate aftermath of the event, and they can continue to occur decades and decades after the event. Many of my clients now are older adults in their 70s and 80s who are dealing with, many of them with childhood and young adult traumas. They have done well for decades and decades in some cases, and then here comes the trauma again when a new trigger comes along. This is a picture of what's called the window of tolerance. The window of tolerance being these two parallel orange lines. And the idea here is that our moods typically, kind of rise and fall. And that's true over a day. It's true over, a week. We can kind of look back and see, I felt up, I felt down. I wake up and I have a big burst of energy, and by 10 o'clock I feel kind of down energy and I need a cup of coffee to bring myself back up. So I'm just kind of going through my day, typical day. Typical emotional regulation kind of look like very gently rolling hills. When people have had trauma and they've had these trauma reactions occur, it changes the way they respond to stimulation. And so they don't have nearly as many normal looking days, typical looking gently rolling hills, right? They have what looks more like these sharp peaks and valleys that go up and down. And as you can see, there's several differences in these curves between the typical and the trauma. For one thing, the trauma reaction goes farther up and farther down, including outside the window of tolerance at the top and also at the bottom. When you exceed your window of tolerance in the upper side, that could look like rage, that could look like paranoia, that could look like panic, it could look like mania, any of those, right? Any of those very, very high stuff. Especially, I often see rage and anxiety at this very high level. On the bottom end, when you go below the window of tolerance and the curve dips below the orange line, this looks like sadness, it looks like depression, it looks like losing interest, disengaging, withdrawing, isolating, very low energy, right? Beyond what is people are able to manage. Another difference between the typical and the trauma pictures here is that the cycles are shorter. Instead of having this kind of like, I have a few hours of feeling up and down, you may have 10 minutes. You may have these very rapid cycles. That's not at all uncommon in people who have trauma. So this is what happens with our nervous system after trauma. Here's what happens to us physically. Having the dysregulated nervous system creates really powerful effects on us and lasting effects. And the unresolved trauma, the trauma that doesn't get handled, doesn't get healed, tends to persist, tends to cause problems over and over again in that triggered fashion. Every time you see something red, for example. And each time that we experience a trauma, we are more susceptible to further trauma. It would be nice if instead trauma made us immune to further trauma. That happens in certain cases with our bodies. Exposure to something makes it less likely we'll get it. Trauma works the opposite way. Trauma accumulates and accumulates and accumulates, and unprocessed traumas just start to build up and stack up higher and higher. So when you meet an individual who's had one trauma, you'll see some impact. If you meet an individual who's had 8 or 10 or 12 traumas in their life, you often will see much, much greater impact. And it takes less and less each time to cause the impact. So here's an example. I had a client who had experienced many traumas over a lifetime and was about 40, 45 years old, something like that. She decided to go back to school as she began to heal, and some of that trauma started to go back down for her, the level go back down. In her first class, she made an F on an assignment. And the F on that assignment upset her so much that she dropped out of school. And it was another year before she felt strong enough to go back and try school again. It had an extreme impact on her. And for most people, an F on a paper would be upsetting, but not traumatizing, and certainly not to the extreme level that it was for her. But she was susceptible because of all of her previous exposure. So it didn't take very much to just tip her over the edge again, and have that reaction that she couldn't manage on her own. Untreated trauma tends to worsen over time, partly because people tend to experience multiple traumas. If someone has, for example, let's say, witnesses domestic violence as a child, evidence shows that they're more likely to have abusive relationships later on in life. They're more likely to do other risk-taking behaviors that put them at risk for trauma again. And as people try to cope with trauma, the things they do to cope sometimes help and sometimes don't. They're sort of like healthy coping and unhealthy coping. If someone turns from discomfort to substance use as a way to help, for example, the substance use itself often becomes a problem, and everything associated with the substance use becomes a problem. It begins to damage their health. It's financially very difficult, et cetera, et cetera. So when you see a person struggling with trauma, they're likely to be struggling with multiple traumas, and they're also likely to be doing at least some things that might be making them at risk for further trauma or worsening the trauma. So it's not just treating the event and the response. There's usually a whole interconnected web of other events, coping behaviors, lack of resources, a whole host of things that need to be addressed. And then just to bring it back again to this idea about communities that have experienced trauma, individual trauma changes us, right? It changes our minds, it changes our bodies, changes the way we behave. And these changes affect larger structures. They affect our families, they affect our communities, they affect the organizations that we're involved in. And so when you have a community that has pervasive trauma, you're going to see a lot of impacts. And one more thing I want to say about impact. The impact on children is more profound than the impact on adults. And that is because children's brains are developing. And as they're developing, they're very vulnerable and very sensitive to everything that's happening around them. They're soaking it up like a sponge. You've had that thought about kids before, right? They're taking it all in. And so as children witness or as children experience violence, as they experience abuse, neglect, as they experience living in environments that are having a lot of trauma, discrimination, racism, poverty, et cetera, there's an increasing risk to them of severe consequences in later life. And this has been studied really extensively. The study is called the ACEs study, the Adverse Childhood Experience Study, where they measured the number of traumas in a very blunt sort of way, but they measured the number of traumas that kids had had on a range from 0 to 10. And then they followed those kids and looked at outcomes in teenage and young adult and adult years. And they see that the more adverse experiences, what we would call traumatic experiences kids had, the more likely they were to have negative outcomes later in life. And that's a very, that for me is a very scary slide. That's a very scary thought, that children are so vulnerable and that our society doesn't do a good job often of protecting children from trauma, that we're not particularly geared towards that. However, it also has a bit of hope in it for me that if we can intervene at the right time, if we can prevent traumas from happening, or if we can get healing for the traumas that have already occurred in children and in their families, that we can then have a profound positive impact on their development by protecting them from the negative effects of trauma. So, scary slide, but also a hopeful one. I want to do another exercise with you, and so please follow along as you see fit, and disengage if you feel like you need to, either way. In this exercise, this is a short guided visualization. It's going to take about 1.5 minutes. I want you to get comfortable in your chair, relax for a second. You may have your eyes open or closed. All you're going to do is listen to me for about 1.5 minutes. Begin the exercise, if you feel comfortable doing so, by taking in a deep breath and then having one of those long, long exhales. I want you to begin to imagine a container. A container can be anything that you like, anything that is able to hold something else. People have used submarines. They've used bank vaults. They've used cookie jars. They've used safes, suitcases, boxes, anything that you can imagine that could hold something. What we're going to put in this container is anything and everything that's disturbing to you right now. So imagine a container that could hold the things that are disturbing you. When you have your container in mind, I want you to take a good look at it and notice, what is it made out of? Notice, what color is it? Notice, how big is it? Notice, how heavy is it? I want you to look at your container and notice whether it has a lock on it or not. If it doesn't have a lock, please imagine a lock for it right now. Maybe even several locks. We want to be able to close this container and close it securely. When you have your container picture in mind, I want you to imagine unlocking and opening your container. And then imagine being able to reach inside yourself and take out whatever is bothering you right now and put it into the container. In some way, imagine being able to pull that out of yourself and put it in the container. It might be memories. It might be negative feelings. It might be negative thoughts. Maybe something is feeling uncomfortable or painful in your body right now. Maybe something's distracting or bothering you in the environment right now. Imagine being able to take all that stuff that's bothering you, disturbing you, distressing you, and putting it in the container. And when you feel like it's all in, I want you to take 1 more minute and scan your body, starting with the feet and going up to the head, finding anything else that feels disturbed, tense, uncomfortable, negative. put that in the container as well. And when everything is in the container, I want you to close the container and lock it up securely. Turn your back on the container and begin to walk. You can walk and walk and walk and walk so far that the container is no longer in your sight. And now that the container is no longer in your sight, notice how you feel in your body. Maybe you feel a little relief. Maybe your shoulders dropped a little. Maybe your stomach felt a little more settled. Know that that container is there, that you can open it at any time, but that you don't need to open it right now. When you're ready to do so, you can open it up and look at what's in it. But for now, you can relax, knowing that everything that you put in the container is there, that it's securely contained and locked up, that it will stay there until you choose to access it again. And now gently, kindly, over a few seconds, bring your attention back to here, back to now, and open your eyes. The goal of that exercise is to be able to take some disturbance in the mind, anywhere from mild to severe disturbance, and put it somewhere else in imagination, right? In reality, we're changing nothing. Imaginatively, though, we're changing everything, because we're teaching ourselves, we're teaching our clients that emotions, thoughts, even bodily feelings can be put aside, can be contained. There is a way to manage this, right? So this is sort of a symptom management tool. How can you get someone calm enough that you can then have a logical conversation with them? These are tools that will help get people to that place. Okay, stopping there and taking some more questions.
Sure. Well, first, I'd like to say thank you for that amazing activity. I really needed it personally, so I appreciate that.
Cool, cool. I'm glad that worked.
We also had a comment from Jordan who said they thought it was amazing and were wondering if we had a printout for it as well. So just putting that out.
You know, I do, and I'll have to send it. So Christiana, will you make a note of that and remind me to send it, and then you can distribute it?
Absolutely.
Yep.
All right.
Thank you. That's a great idea to get it out to everybody. Thanks.
So we had a question from Michelle a little earlier on in this segment that said, can you speak about the proverbial trauma that is beyond any memory, but is stored in the body?
Yeah. This is thank you. That's a great question. Trauma remains in our bodies and in our minds, and it remains both cognitively and emotionally. So really, those are the three major realms I'm always thinking about in treating trauma: the physical, the cognitive, the emotional. And there's some evidence to show, the evidence is still mixed on this, but there's some evidence to show that things that happened to us before we remember, when we were so young that we have no memory, can remain in our brains and in our bodies and having impact on us. And that can even extend at least a month or two pre-birth, that things that happened while we were in our mother's womb can impact us. There has been some evidence that that is true. And as I said, the evidence is still mixed. And so I can't 100% rely on that. But it has been my experience that people's memories remain in their bodies. And here's how I see that happen. Here's an example of how I see that happen. Shields up, difficult story. I have a client who was asleep as a child in the backseat of a car, and the car, probably at age 5 or 6, and the car drove off a bridge and into a river, and they were rescued. But their experience of that event, and they remember it, their experience of that event is of waking up with water all around them, and they were already struggling for air. They already, had water in their lungs and were starting to choke. And that's particularly a hard kind of trauma that starts when you're asleep or when you're unconscious or when you're intoxicated, because you already are impaired in your processing, and then the trauma creates further impairment, so it can be very difficult. But this client, even though she'd had trauma therapy and she had done really well in it, continued her whole life, and I met her when she was about 40, continued in her whole life to experience breathing difficulties. She developed what looked like pretty severe asthma attacks. No asthma medication tended to help. She would have panic attacks where she would feel like she couldn't breathe. She choked frequently. She would try to drink water, and even just the act of drinking often sort of caused her to have her throat close, and that feeling of I can't breathe. And there was a lot of panic associated with the feeling of not being able to breathe. And I can't prove it, but I have a very strong hunch that that was related to that early trauma experience. And so some trauma therapy that focused on the body. It was a somatic experiencing therapist that helped her ultimately, that was able to help her relax into sleep without starting to worry and panic, that helped her relax into breathing, into drinking water, into being in water in the bathtub or a swimming pool. She really had very strong, severe body reactions. So absolutely that's possible, that people have body reaction that persists. Sometimes even they don't know the connection, and how it started. Many, many remarkable stories about how people discover that for themselves or in therapy. I recommend, and this is a book, it's on the reading list at the end of this presentation, I recommend the book called The Body Keeps the Score. That's The Body Keeps the Score by Bessel van der Kolk. That information is on a slide at the end. He does a remarkable job of explaining how the body is affected and then how to work with the body to help overcome that. What else?
So we had a question from Reggie a little bit earlier. Is there such a thing as transgenerational racial trauma? Can you talk a bit about this?
This is a really interesting question, and it's one I'm really involved in, following the research. I teach a class about trauma at the University of Texas, and I want to give folks the most up-to-date information, and so I'm trying to stay current. This is an evolving field. We don't have a lot of research about it yet. Like so many other things related to race, it has not been a priority for academic researchers for a long time, and that is starting to change slowly, particularly as we get more researchers of color, but we don't have a big evidence base yet. All of that said, there is some preliminary evidence that severe trauma can change the way that our genes are expressed. It doesn't change our DNA itself, but it changes the way that the DNA is manifested in our bodies. So you may have, for example, DNA that predisposes you to a condition. That doesn't mean you're going to get that condition. It just means the chances are higher. It's that same way with all of our genetics, that any of our genes can be expressed or not expressed. And so there's evidence to show that the trauma of racism is profound, that it affects people's minds and bodies very severely, and that can even manifest in something that could be passed down to our children, not by changing our DNA, but by changing how our DNA gets expressed. So make it more likely, for example, that you would have mental health challenges, or that you would have Certain types of diseases, diabetes is one that seems to be very responsive to trauma. And in highly traumatized populations, there's a very high incidence of diabetes that seems to be correlated. Racism is, and really any of the isms that you would like to talk about, right? Any of that list have such a profound impact on us because they start from birth, they persist our whole lives. They are that kind of personal trauma where someone else is targeting, right? Someone else is doing that thing to us. It's not an impersonal, accidental kind of an occurrence. It's something a person deliberately did or said that affects us. And it's happening so frequently. When they really start to examine, you may be aware of this data, when they really start to examine how often does someone experience discrimination, it's multiple times a day. And that's a huge impact, right? Just to kind of wrap my head around how much trauma that might create in the person receiving that behavior is hard to do, right? It's kind of mind-blowing to consider. And I'm excited to see that it's starting to get attention in research, but it's also starting to get attention in people that are developing interventions that are race-based, that are sexism-based, that are trying to deal with people who've experienced homophobia or transphobia, all of that, right? And so that's a great development, I think. Thank you for asking about that.
All right, let's do one more question.
That sounds good.
You touched a bit on this, but it's from Bianca, and it says, is there a correlation between higher instances of autoimmune disease in people that have experienced trauma?
Yes, absolutely. I'm going to look at my slides for a second. Excuse me while I look down at my lap. I have my slides right here. I put a list in the notes of one of these slides. It's the slide that says physical and social impacts. I'm not able to see the notes here, but the notes are available on the PowerPoint presentation. And that includes a list of just some of the physical impacts. There's a host of diseases. Autoimmune is one of them. It's diabetes, it's cancer, it's lung disease, it's heart disease, it's obesity, it's you name the physical health problem. It's almost everything you can imagine is exacerbated by trauma, not necessarily caused solely by trauma, but made worse by adding trauma into it. Yeah. The other, I'll just say as an aside too, if you guys download these slides, be sure and download the notes at the same time the slides, because most of my talking points are in the notes.
All right. Those are all the questions for now. So.
Okay, thank you. Thank you. Thank you. So how do you know when you're talking to someone who has trauma, right? What do you recognize? How do you diagnose it? But even more importantly, how do you just see it? How do you learn how to see it? Well, first of all, trauma is very prevalent. If you think back on that list of all the different events that I threw up there, those events covered a huge spectrum of things. Many people have been through at least one of those events. Here's the numbers: 50 to 90% just in the general population, higher numbers than that in the mental health population. Trauma is a bit hard to recognize sometimes. One reason is because trauma has a very high comorbidity rate, about 80%. The next highest comorbidity rate is substance use, and that's has a comorbidity of about 50%. So trauma is very likely to co-occur with other mental health conditions. And what that means is somebody's going to show up and they're going to report to you lots of different symptoms, and you may have hunches about those other symptoms and diagnoses that you would want to use. Trauma doesn't necessarily just jump out at you. The other reason trauma is challenging to recognize is because it mimics other disorders. So the criteria for diagnosing someone with PTSD, for example, requires that they have mood disturbance, which looks like mood disorder, and you might be tempted to diagnose depression or bipolar. It also requires you to have symptoms that look like anxiety. Some of the criteria, for example, are restless and unable to sleep, racing thoughts, exaggerated fears. This sounds very much like the anxiety criteria. And so you may have a hard time distinguishing that. Trauma is very comorbid with substance use, and so you may have trouble distinguishing between trauma and addiction. Trauma, even in flashbacks, can look a little bit like psychosis. And some people with trauma get diagnosed with schizophrenia when what they're really experiencing is not hallucinations, but flashbacks. And so overall, trauma is pretty challenging to recognize. We'll say a little bit more in a minute about how to do it, but here's another couple facts I think about recognizing trauma that are important. When we assess folks for trauma or PTSD, women and members of disadvantaged populations are more likely to have trauma than are men and that are folks that are white. However, white males have the highest rate of diagnosis of PTSD. This is kind of, took me a little bit to wrap my head around why was this so? And here's why. The military requires every person leaving the military service to have an assessment for PTSD, among other things that they do. So as folks are getting discharged, they're getting a PTSD assessment. The military is primarily made up of men and primarily still white men, although they have a high minority population, and that population's growing. But many white men have been diagnosed with PTSD because of their military service. Members of other populations, non-military personnel, especially women and minorities, often don't get mental health assessments, whether that's lack of access or lack of recognition of the importance, who knows, probably a little bit of all of that. But women and members of disadvantaged populations are more likely to have PTSD or trauma, even though they're less likely to be diagnosed. However, on the other hand, don't assume that because someone is a member of a population or has had a certain kind of experience, that they must have trauma. So when we look back at the Iraq and Afghanistan deployments in the military in the last decade ago or so, and up to still happening, about 1/3 of people coming back from those deployments have PTSD. Whether they had it before they went or it developed while it was there is not entirely clear. But they definitely have PTSD on returning to the United States and discharging from the military. However, 2/3 of them don't. So again, this is one that I kind of have to wrap my head around. I have to really think it through. Why do 2/3 of the people who go to be deployed in an active military combat zone not get PTSD? That's really kind of a surprising result to me. Here's what turns out to be at least part of the explanation. People who had trauma in their childhood or young adulthood before joining the military are much more likely, probably at least 5 times more likely, to develop PTSD while in the military. People who did not have childhood or young adult trauma are much less likely to develop PTSD. And that goes back to this idea that trauma is additive, right? So if you already are having some sort of moderate trauma in your background and you have one more experience, you're pretty high up the scale. On the other hand, if you've got nothing and you're right at the bottom of the scale, one experience doesn't get you very high, right? And so I think that's how I explain that in my head. So here's my clues. When I meet someone and I'm thinking about the possibility of trauma, these are the things that I am looking for. And this one that's in orange is the most important one. Trauma memories that don't resolve in time. So if people come and they say, I broke up 3 years ago with my boyfriend and I still obsess and I can't get past it and I feel stuck. I go, okay. Or if they say, my life was going along fine and then I got fired from my job. And then I got sick and got a diagnosis of some illness. If memories are the thing that are bothering them, or if they come in and they say, I'm fine, but I have terrible nightmares, or I'm coping, just doing great in my family, but every time I look at my kid, all I can think about is myself at that age. These are clues, right? They're stuck in the past. They're stuck in things that have happened in the past. They're troubled by the memories. So that feeling of stuck, that feeling of being troubled by memories. Another thing that I tend to see very commonly, and so I just look for it now, is people who have tried many medications with very little relief. There is no medication that helps with PTSD. There are medications that will help with the symptoms. So you can have treatment for your depressive symptoms. You can have treatment for your anxious symptoms, but no medication will cure PTSD. And so if people have tried medication after medication, particularly several different kinds of medications, and nothing seems to have helped, that's a clue to me that it might be trauma underlying anxiety or underlying a depression. The other thing I pretty commonly see is different diagnoses. My record is I had a client come to see me who had 13 different diagnoses over 7 years, with several hospitalizations and several involvements with different mental health professionals. Clearly, nobody knows what's going on if they have to give you 13 diagnoses, right? And so that was a clue. So when people come and say, I've had this diagnosis, this one, this other one, that other one, that's I say that I have antenna. These are my antenna. And when I hear certain things, my antenna go up for trauma. So when I hear diagnoses, my antenna go. Yeah. So what do we do? What if we recognize trauma? What are our options? First of all, and I think this is the most important one, work on staying calm yourself, being aware of your own reactions, but not overwhelmed by them. If you're going to work often with people who have trauma, you're going to be well served by having a way to help yourself stay calm. And so having the practices of things like that container exercise, being aware of your own reaction, being able to put it in a container where I'll think about this later, but it won't interfere with the session right now, right? So having a way to feel it, but put it aside, know that it's there, but not let it overwhelm you in the moment, because you need to connect with the client. And it's very easy to become dysregulated by some clients with trauma. Very, very easy. They are very dysregulated sometimes. And so staying calm and grounded sounds simple, probably not really that simple in real life, but learning that and practicing that skill. Secondly, being able to reach out to support them in whatever ways they need, with being present, being attentive, being caring, being warm, being ready to engage. And again, this is much easier said than done, very challenging to do with a client that is very dysregulated, but helping them feel heard, helping them feel understood and seen. And of course, these are things that you do with every client. They're not unique to trauma, but they're sort of especially important with trauma. And this third point, I think, really makes that clear. Clients that are emotionally dysregulated are going to be beyond further help until they get regulated. We have to be in the regulated state in order to be open to Hearing ideas, working with other people, making good decisions, communicating clearly, all of those things that you need the client to be able to do. So learning how to help the client emotionally regulate so that you're maintaining your own and you're also helping them. And then the two of you will be able to have the effective interaction. So how do you help clients emotionally regulate? We're going to get in a second to some grounding techniques. Use grounding techniques. I've taught you a couple, the breathing, the container. I'll teach you a couple more. And there's many, many, many of these available on the internet. Look and find them. That is how I found them. Use grounding when people are in crisis, meaning if they're so dysregulated that they can't even communicate, you've got to find a way to help them come back to reality and be present in the moment. You can then use emotional regulation skills once they're calm, with people who are calm. And if you need more, and you see that, therapy isn't helping them, talk therapy or whatever type of therapy you're practicing isn't helping, they may need a trauma specialist, and that would be a good thing to consider if you've gotten this far and things are not progressing the way you want them to. And then finally, and I don't want to forget this piece, I think it's very important, you have to close the loop. Remember that you got dysregulated by being with this person. You contained it, or you put it aside, or you found a way to manage it, but it's still there. It hasn't gone anywhere. It's just waiting. It's just waiting for you to get back to it. So go back to it, right? At that point, what is it that you need to do to take care of yourself after the interaction is over with the client? You then have to return and take care of yourself. Many, many things are possible. When I was in that job where I worked with foster youth, I was very dysregulated. Often at the end of the day, I was a fairly new therapist and I wasn't as skillful as I am now. And I was also hearing some pretty tough stories and getting trauma on me. I had that sticky feeling that, people's trauma was in my body, and I could feel the disturbance, and I could feel the negative thoughts and the negative emotions in my head. I did something very silly. I'm old now, I'm going to date myself. I had a cassette tape of comedians, and I would play that on the way home. And at first I wasn't paying attention. At first the tape was just running and I was just in my head and distracted by how I was feeling upset. But in my long commute home, by the time I was partway home, I had started to listen to the tape. And by the time I was getting close to home, I had started to respond to the tape by smiling or laughing. And by the time I walked back into my house in the evening and reconnected with my family, I had done enough processing that I could then be present with my family without getting the trauma on them. I didn't have to feel compelled to talk about it or act it out. I was able to go back to my calm and grounded self and connect with them the way I wanted to. So whatever works for you. Some people like to express, some people are quiet, some people want others around, some people want to do it alone. For some folks it's physical, for some folks it's mental. Whatever you find that works for you, try lots of different ways is my advice, and see what will work. This is a page about grounding technique, and I'm not going to go through all of them. I suspect you're aware of at least some of these, but maybe not the whole list. And maybe you have some that you would add to this too, that you know. So these are roughly in the order that I would try them with a dysregulated client. First of all, you just have to have the client know that you're present, recognize that they're not alone in the room, kind of come back to connection with you. And so I want them to look at me. That's where I start. And then I go through sort of a series of things where I ask them to connect with the environment. I ask them to activate the logical part of their mind. They may be really stuck in their feelings, and I want them to come back to being more rational. I want them to come back into their senses. I want them to do things that help their bodies feel secure. And then I want them to comfort themselves until they feel ready to engage. So this is all sort of pre-engagement stuff. If somebody walked into my office and they're hysterically crying, for example, or they're so deep in a flashback that they don't know that they're in the room with me, this is where I would come, is to this list and to start to work down from the top to the bottom, increasingly challenging things for them to do, increasingly getting in touch with here and now and me and what it is that we're trying to do together. I'm just going to leave this list for you here. And I have one more exercise for us to do. And then we'll get to some questions. Again, this is going to be an exercise where you just listen to me for about a minute and a half. And so again, participate as you feel able to and willing to. Don't if you don't want to. If you're going to participate, you can, again, get comfortable in your chair. It often helps to sort of wiggle a little bit, make sure you're seated securely, make sure that your legs are uncrossed and your feet are flat on the floor. That's usually the better position for doing any of these mindfulness exercises. Make sure your arms are supported, your back is supported, get your body in the right spot. You can have your eyes open or closed. Start by taking a deep breath and a big exhale. We're going to gather up stress and tension and discomfort and pain. And so I want you to start with your feet. I want you to turn all of your attention to your feet and notice anything that feels tense, painful, uncomfortable, anything that feels disturbed in any way. And if you feel any of that, I want you to imagine that you're able to reach down to your feet in your imagination and pick up what disturbs you, pull it out of your feet and hold it in your hands. And then I want you to continue the scanning. I want you to scan up your calves, your knees, and up your thighs. And just notice, is there anything in the calves, the knees, the thighs that feels tense, tight, tingly, numb, uncomfortable in any way? And if there is, gather it up in your hands and hold it in your hands. Add it to what you have. Start gathering up all the tension in your hands. Then I want you to feel your bottom where you're sitting on the chair. I want you to feel up through your belly and up through your chest and up through your back. Just pay attention. Your rear end, the belly, the chest, the back, any tension, discomfort, pain, anything bothering you, anything feels out of the ordinary, uncomfortable, gather it up. Hold it in your hands. Notice that what you're holding in this hands is this kind of like squishy, icky stuff that you can kind of smush together. Now I want you to scan your hands, your arms, all the way up to your shoulders. Again, removing any tension, pain, discomfort, holding it in your hands. I want you to keep scanning up your neck and through your face and through your scalp, relaxing by removing whatever feels uncomfortable. And now you should have a big ball of this icky, squishy stuff. And as you're holding that, do one more scan, feet, legs, torso, arms, head, checking one more time just to make sure you got it all. Now you have this big ball of ick. Start to give it a squish. Notice that as you push on it, you can kind of make it more compact. Get it down to a basketball. And then squish it a little more. Keep going. Keep going. Give it a really good squeeze and see if you can get it down to like a softball. And then continue to press on that softball. Squeeze it a little more. Get it all the way down to about the size of a golf ball, to where you can just have a very condensed ball of ickiness. It's time, if you have your eyes closed, it's time to open your eyes. I want you to look around your space, and I want you to find a place where you can set this ball and leave it. And I want you to imagine placing the ball in that spot and then walking away from it. Knowing that that ball is there, but also knowing you don't have to do anything with it, that it will be out of your way wherever you have left it, and it will stay there. Okay, that's it. I've got one more slide to show you, just briefly. Nothing of overwhelming importance on here, just to show you a lot of different ways that people emotionally regulate. A lot of different things. This is just some pictures to give you a little bit of a visual. Depending on the situation, depending on what you're capable of doing in the moment, depending on what you like and don't like, you might pick any one of these or any of the other things that might work for you. And you might suggest these things to your clients too. I am done, and I'm ready to hear some more questions.
Right. Well, we just have one question at the moment. It's from Reggie, and it says, is hypervigilance a sign of trauma?
Yes. 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 The criteria for PTSD, which is one of the trauma diagnoses, has a section that looks like depression symptoms. And so it's, sadness, lack of interest, loss of pleasure, isolating. It has a section that looks like anxiety, which has things like restlessness, inability to relax, sleep disturbance. It also has a section about reactivity, what they call reactivity, and that includes hypervigilance. And then it has a section about I forget what they call it now, but it includes hallucination, flashback, nightmares, those kind of like out of reality experiences. That sounds a bit like schizophrenia. That's a hard distinction to make between a hallucination and a flashback. Yeah. But yes, absolutely hypervigilance.
Right, and that looks like the last of our questions. I know a few people were curious about receiving their CEUs and other materials from today, so I just want to let you know, for the folks that weren't here in the beginning, I'll be sending out those certificates in the next 7 to 14 days. So thank you for your patience while I get those together for you. Additionally, the PowerPoint, contact info for Dr. Hill, and other materials from today will be sent out post-session. We have recorded this as well, and once we have that up on our YouTube, we'll send that link out to you as well. All right, anything else, Dr. Hill?
That's it. Thank you all for coming.
Thank you all. We appreciate you joining us today, and stay tuned for our next Alumni CEU that will be coming up in May. It's going to be on May 20th, and that will be a session on ethics. So I know that's something all of you licensed practitioners out there need. So I hope to see you again then. All right. Thank you all.
Bye-bye.